So, a very warm welcome to you all to this afternoon's session of the Nuffield Trust Health Policy Summit. My name is Richard Humphries. It's my pleasure and privilege to be chairing the session this afternoon. I'm involved in a number of different things in the world of health and social care, including being a non-exec director and deputy chair of my local NHS trust here in Herefordshire. I'm also a trustee of the Association of Directors of Adult Social Services, and I'm recently joined the Health Foundation as a senior policy advisor. So in this session, we're looking at the big question of how can COVID-19 help us to see through big changes in health care services. And to help us think that through, we have three excellent panelists who are each going to offer what I'm sure will be a distinctive and thoughtful response to that question. This will be a 1 hour long session. It's live streamed, but you can watch it afterwards on demand after a period of time. Before we actually get into the meat of it, for those of you who don't know about the Nuffield Trust, it's an independent health policy think tank. It looks at a whole range of health and care policy issues. And every year has this wonderful summit, which is really an opportunity to give people who work in health and social care some time out, an opportunity to reflect on the big issues of the day. So as the session proceeds, it would be great if you could use the Q&A box to post any questions. And then my colleague, Cami Ung from the Nuffield Trust will try and make sense of them, and we'll have a discussion when the speakers have completed their presentations. There is an evaluation link at some point which we would like you to fill in. It helps to kind of learn from the experience. And it would be great if you could tweet, ideally about this session, using the hashtag #NTSummit. So let's get into the meat of it. I think it was Lenin who said that there are decades when nothing happens, and there are weeks when decades happen. And I'm sure you've heard that before. And I think we're very much in the latter territory across a whole range of public services right now. But how can we make sure that the good things that have happened during COVID, the improvements and the big changes in ways of working, how can we secure them? So let me go straight to our first panelists. Now, I'm not going to kind of go through their biographies because you've got it on the website, but our first panelist is Professor Partha Carr, who many of you I'm sure will have heard of, very active on social media, really enjoy his tweets, National League for Diabetes hospital consultant. Partha, what are your thoughts about this?
So first of all, thank you very much for the invite, and I think very much a pertinent topic, simply because hopefully, fingers crossed, we are on the way to getting out of the nightmare we have, and then we start planning ahead. I think from my perspective, I can probably divide the answer into two halves, which is a local perspective and the national perspective. On a local one, I think it's been quite fascinating to see how simple things have happened, which you would scratch your head and wonder why it's not happening. So I remember I used to be clinical director, and I remember having to go to 11. And I remember when the number specifically, because I've always thought about writing it up for a BMJ winter, edition. I remember having to go to 11 meetings trying to explain to somebody as to why using video consultations was a good way of, interacting with people. And I tried at pain to try and explain to them every weekend I could somehow talk to my parents in India, but I couldn't talk to the person down the road. And some of the questions they were just unbelievable. Things like, do you need a chaperone to be with you? What kind of governance? What happens if somebody hacks your call? And until this day, I haven't quite understood why the North Koreans would like to hack into a diabetes consultation, understanding what glucose levels, but there you go. But then the pandemic came and voila, it was like just happened. So I think on a local level, I don't see myself, and it was interesting talking to many of my colleagues in the department who do not see themselves going back to a packed clinic session in a diabetes world. We would like to keep very much a virtual set. I think, I work with colleagues of different generations. Some of them have been very reluctant to move to a virtual world now. All of them pretty sold. No, this works really well. and we will see them if they need to. So I think on a local level, that's really accelerated. On a national level, I think, it is a bit last couple of years has been documented in different forums, my sort of struggle with the system to get technology adopted, even with the national role. And this year, the fast tracking of that has been quite phenomenal to see. We suddenly have got this whole, interest, energy to try and land sort of online, virtual, digital work. And I'll give you one example of that. Over the last 7-8 years, the way education program in diabetes is done is it has to be face-to-face. And I've asked this many a times to the provider, why does it have to be face-to-face? And they say, well, it's very important. They have to see us. Otherwise, they don't learn anything. The only problem with that philosophy was that if you look at the National Diabetes Audit data, guess what? Nearly 60% are referred, only 4% attend. And as I keep saying to people, the best education program in the world is the one the person attends. There's no point in just referring them to a program if they're not going to go there. And that's been quite an interesting thing. So I think from my perspective, I think it's opened up lots of doors. I think lots of providers have been forced into an area where they've been, moving into a digital world, as it should be. I mean, it's 2021. I mean, how can you not have emails and phone calls and video consults with people in a healthcare setting? I think the billion-dollar question, which I'm sure others will pick up and we'll have a conversation as we go along, is what happens after this? Do we start reverting back to type? Because, the individuals are still the individuals. Are we still going to look at data? And I'll finish with this bit and let the others come in with their views. Is I think the way we look at anything digital in the NHS or any setting in the healthcare system is very archaic. We want randomized controlled trials. And I say this tongue in cheek, and I've said this about NICE, and I've got a great relationship with NICE about this. But the way the pace at which NICE works and the way at which NICE does adapt, looking at, we would have probably been approved Betamax at the present moment of time, while all of us are sitting on watching Blu-ray. And that's the problem with digital and how we adopt science into it. Having said that, NICE is getting far better in its adoption of it. So I think those are the main issues going forward. How will the system keep on reacting, and will it keep the good things or will it not? So that's pretty much my overview as to where we are or not. I would be very keen that they do keep a lot of the things. And in a world of chronic disease like I do in diabetes, with all the remote monitoring and all the downloadable systems, come on, you can do diabetes care a lot by virtual working.
Arthur, that's a cracking start, and you finished really by saying that how do we get rid of the bad things? How do we hang on to the good things? And how do we have the wisdom to know the difference, possibly? But anyway, let's move on. So moving on to Dr. Anna Barham-Brown, who has an interesting mixture of roles, Hannah, as a BMA Council member and Deputy Leader of the Women's Equality Party and a disability campaigner. So welcome. Over to you.
Thank you for having me. So I'm going to come at this at a very different angle from Partha, in that, as you can probably tell from my bio there, I'm also a GP trainee. So I'm very much community-based. And whilst I love the fact that for ease, being able to pick up a phone and talk to a patient is so much easier for them and for us often, I think we have lost something in having to only do that a lot of the time. So I think there's a balance to be struck, and different ways will suit different patients better. That's really important. And I think one of the most important things as we move forward in terms of the new ways of working is that, yes, we don't go back, but we also make sure that they are accessible and they work for everybody. Because for some people, in terms of internet poverty and all that sort of stuff, video consultations are really challenging. So we need to think about how we make this accessible for all. But I'm going to kind of come right back to look at, how we entered the pandemic, because I think at the very beginning, we were being told that COVID was going to be the great leveler and the great equalizer. And I would argue that actually we've seen completely the opposite. I think that COVID has actually, if anything, been the great revealer. It's shown the massive health inequalities that so many of us knew existed. If you'd read Marmot's work for the last, 10, 20 years, we knew health inequalities existed, but I think it's really put a spotlight on them in a way that we've never seen before. So if we look at the way that COVID has impacted on different communities, 60% of all COVID deaths have been amongst disabled people and people with chronic illnesses. In terms of disability itself, we saw council's duty of care suspended. We saw no uplift for personal independence payments or carers allowance, whereas we did see a £20 uplift a week for universal care credit. And that's disproportionately impacted people. We've also seen other horrendous statistics, and it's important to remember that health does not exist in a vacuum. The wider social impacts of this have a huge impact on our patients' overall well-being and their health. So when domestic violence has gone up 60% during lockdown, I am scared for the welfare of my patients, and that's going to have an impact on how I support them going forwards. When mums who are on the lowest income are 8 times more likely to have lost their jobs due to school closures, that is going to have an impact on how they are in terms of their health, and also on their family's overall health as well. And as a GP, this is the kind of holistic care we need to be thinking about. But I think even before the pandemic, as I said, we didn't start in a great place. So we need to start talking about the fact that Black women are 4 times more likely to die during pregnancy and childbirth. That prior to the pandemic, there were 112,000 care vacancies in the UK. Those are huge, huge issues that we hadn't dealt with before the pandemic, and we are paying for those now, and our patients are paying for those now. And so I think we need to look overall, we need to look at care. And as we build our way out of this, I keep hearing build, 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 and jobs, 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 and other really frustrating 3-word slogans. We keep seeing, you know, random press conferences with the Prime Minister standing in front of like hard hats and fluorescent jackets, like a Bob the Builder set. We know that an equivalent investment in care to construction has a better overall outcome for the economy on a variety of measures. And that's been shown time and again by the Women's Budget Group. So I think what we need to be talking about is how we provide a care-led recovery, how we make sure that care workers are actually being paid a real living wage. The average wage of a care worker in this country is £8.50. Now, if a real living wage is £10.85 in London, what are these people living off? And when those gaps, which we know existed because of all the vacancies we talked about, when those gaps are there, who is picking up that burden of care? It is the unpaid carers whose carers allowance didn't go up during the pandemic despite rising living costs. All of these things will have a massive impact on health. And if we're really going to have a healthcare revolution, we need to make it an overall care revolution and insist that we are putting our investment into that rather than other glory projects, which will give us, I don't know, more skyscrapers and offices and stuff that we don't really need. So my big thing is, if we have a healthcare revolution, yes, please, let's make it equitable, let's make it care-led.
Anna, thank you. That was a rousing effort to move us on actually to the bigger sort of platform of issues around population health and wider social economic circumstances in which people live. So that takes us on to a different level. That's great, thank you. And our final panelist from a different perspective again is Adam Lent, who runs the local network, the new local network, which is a local government-based network. And for those of you who are familiar with the YouTube genre of Sandforth Parish Council, I won't need to remind Adam that I have read the standing orders and I do have authority. So Adam, looking forward to hearing what you've got to say.
Thank you very much. It's a bit distressing, really. That's people's main image now of local government is that 30-second or whatever it was, a YouTube clip. But anyway, I shall do my best to move on from that. So as Richard said, New Local, which is a think tank I work for, is a network of councils around the country, but we're increasingly working with healthcare organisations as well. And in fact, what we're finding, many of the challenges that local government face are in many ways similar to the NHS and the wider healthcare system. And I think, in answer to the key question here, has COVID been a catalyst for a healthcare revolution? I suppose my answer is not yet, but it certainly should be. much like Hannah, I think there is a need for a fundamental shift in the way that we think about health and social care and care more generally in the country. And I say that because we all know that there is a massive demand crisis for healthcare and public services generally in this country. Demand has been rising for many years, and the complexity of demand has been rising. And COVID is only going to add to that in really significant ways. I mean, we know obviously that there are some very long-term impacts on people's health and well-being of those who've contracted COVID, and they are going to need ongoing care. There's of course going to be ongoing infections, even once we're through the sort of most intense period of the pandemic. COVID is not going to go away. It's probably going, as many people know, it's going to continue to be an annual spikes in infections. We've got the economic disruption from the pandemic and from lockdown, which always increases demand for public services and for healthcare. And for anyone who's had a chance to look at the Defence Review that came out this morning, that itself points out that the chances of further pandemics over the next decade are pretty, I think they describe it as a realistic possibility. And then we've got things like antimicrobial resistance, which the Defence Review pointed out is going to have a massive impact globally on health and in the UK. So the demand pressures are only going to rise. And my fear is that if we don't, as a country, get on top of those demand pressures, the fundamental principle of universal free healthcare, which has underpinned the NHS for 70 years now, is going to come under such severe pressure that it simply won't be able to withstand it. And we will move towards a fundamentally different type of healthcare system, which is going to be severely rationed, or which there are going to be charges for healthcare. In a way that in many ways local government has already been going over the last decade because of austerity, moving towards severe rationing of social care, although we don't call it rationing, but that's what it is, introducing extra charges for universal services. You want to see your future in the NHS, look to where local government has been going over the last decade, basically. So we need to get on top of that problem. For me, and all the work we do at New Local, and we do a lot of work with councils trying to think through this, is the need to move to a much more preventative model. We all know that. We all talk about the need to move towards prevention. But I think it needs to stop being an add-on. It needs to become the fundamental goal of how we understand health and care in this country, is about preventing people getting sick, preventing people needing care, rather than treating them when they get ill. And for me, that is all about empowering communities, giving communities, networks of people in local areas, the power, the resource, the responsibility to look after their own health, to lead on their own healthcare, and take it out of the hands really of the institutions, the big institutions that provide health and care. It has to be a collaboration, a fundamental collaboration between the institution and the community, but essentially this is a community-led thing that has to happen. And the final point I would make is that all the work we do with councils shows that if you're going to move towards that more preventative, community-led type model, there's many ways to do that, but the absolute starting point is organizational culture change. There has to be a fundamental shift away from that paternalistic, we know best type attitude that permeates the public services and has done for many decades in this country, and permeates the NHS, unfortunately, towards an approach which understands that actually the solutions to the big problems we face around healthcare and other issues are to be found out there in the community, not inside within your institution. So moving to a much more community-led model. And there's some great examples in healthcare around the country that are leading the way on this. Initiatives like Healthier Fleetwood, like the Vanguard project in Morecambe, Viaduct in Stockport, but they always feel marginal. They're always on the edges. The emphasis is always on acute response and acute care. And basically we need health leaders and particularly politicians to really recognize there needs to be this fundamental shift towards prevention, and that means empowering communities rather than marginalizing them. Thanks.
Adam, that's great, thank you. And I think you were kind of building on a lot of the comments that Hannah had made, really, about social determinants of health and the need for a bottom-up approach. Although I have to say, judging by the recent white paper on the NHS, which appears to suggest that the answer to our current issues are more levers and controls from the centre. I just wonder whether the right lessons are being learned here. So that we might come up with that in the discussion. Okay, so that's a cracking start from our three panelists, and we have a few questions coming in now. So Camille, do you want to take us through some of the questions, or shall I
yeah, I can do. So there's a few questions that have come through about how do we know, so one from Stephen Black, who's Chief Analyst of Ask My GP, would like to know, so big agreement that changes are required, but how do we know which of the changes that have worked and what mechanism will ensure that changes that are obvious to experts now will be obvious to government in the future?
Yeah, okay. We'd like to have a go at that. Partha, that might be something you
I
might.
I can definitely have a go. I mean, I think it's quite interesting because yesterday, some of me have picked up Sam Shah, mentioned this term called vanity metrics, which a lot of thing is more about X has been done, but then you go like, well, what does that actually translated into as far as lives of patients are concerned? And I've always said that. I mean, I'm always fascinated by the NHS's love for process, but actually not much for outcomes, if you look at it. So if you take a step back, you take back all the heated, the people, feel quite exercised, understandably, about the NHS being an amazing body. And I said, the pandemic response is a bit like that, isn't it? If you take a step back, what have we done in the pandemic? We have done some amazing science. We've got some brilliant research, some, great academic issues, some great data. But as far as the outcomes are, due to a combination of, you could say, lack of resource, variation, and clear leadership, etc., the outcomes, which in a pandemic really should be measured by death, we haven't done very well. So, and that in a nutshell is where we are, you see also with this particular thing. So to the question raised, this is the problem. So if you look at the metrics, it says that lots of people have got it in their system. The metrics also say that not many people are actually using it. Yeah. So you are stuck in the first step that everybody's ticked a box to say, yes, we've got video consults where we are. But when you start off on that journey, you also don't have any metrics set out. So for us, for example, if I do a digital intervention, the basic thing should be touching upon what Hannah and Adam mentioned. Okay, this is an intervention is it going out to everybody irrespective of the deprivation index? I want to see that. So that was something that we drilled the team to do. I want to see all the 5 bars coming close to each other, right? I want to see that actually it's improved your diabetes control. I want to see it's improved or reduced hospital, because that's the next step for me to go to NICE and say, guys, we really need you guys to now endorse this so we can do a bit more wider. And to Stephen's question, that is a fundamental problem with a lot of digital interventions. None of those are actually taken into account. It's seen as like a golden ticket, but let's start. Digital is very exciting. It's fantastic. Let's get an app. Let's get something. But you haven't set out on the journey with any markers. So when the question comes from Stephen, quite rightly, so how do you know it's worked? The answer is, well, we don't really, but we rolled it out. And thereby, when it goes to the next poor commissioner sitting in an ICS, they're going like, well, if you want me to invest some money, where do I go next? And all of us in this call have been inundated with examples of, here is a project which we have for 12 months. And you go like, so who's going to fund it after 12? And well, we don't know that. The system will fund it. And you go like, well, the system doesn't have an infinite pot of money to fund it. So I think that's the problem with the question, is that we don't have any markers to set up with. So at the moment, if Stephen says, how do you know which one will work? The answer is, well, we don't. And thereby it falls down to the next hurdle. About how do you invest public money?
Okay.
Can I just jump in very briefly?
Please, yeah.
Thank you.
Hannah.
So I completely agree with Partha. Shocking. But I think there are two elements to this for me. Firstly, one of the greatest things we have seen during the last 18 months is that when NHS staff are given the freedom to innovate, we do incredible work. And that has been replicated time and time again, because we know the communities we work with. We know our patients, we know what's needed, we know what will work for some and not for others. Like a great example of that recently is we've seen vaccine buses going out because we know that trying to get vaccines to people who are experiencing homelessness or to traveller communities can be particularly challenging. And so we've had amazing GPs around the UK getting buses and like filling them. I've seen WhatsApp groups of flourishing, kind of talking about how do you clean your hands and what kind of sink do you use, and like sharing all of these skills and knowledge. That's a fantastic example of how much we can innovate if we're given the breathing space and the time to do so. So we need to ensure that we work in a system that gives our clinicians the opportunity to do what we do best, which is caring for our populations. I think the other thing from a disability perspective and from a service user perspective is that we have this concept in the disability community called co-production. And I think one of the problems we have in the NHS is that we tend to ask people how things are working after the event. So you'll go into hospital, blah, blah, blah. And then as you come out, you'll get a friends and family survey saying, would you recommend having this appendectomy again? Bonkers. That is not the way to co-produce. Co-production is all about the idea that every single person involved should have ownership, and every single person involved should be from a diverse background. You should have patients and service users from the very beginning of our processes, because they're the ones who, coming back to Stephen's question, will tell us what's working and what isn't. We need to be working more in partnership with the people we're there to care for, because until we do that, it's very difficult to know what works and what doesn't. So I think we need to make sure the NHS is actually adopting a proper co-production model with service users from the very first principles in order to ensure that these measures actually work for everybody.
Yeah, and I suspect we would all say amen to that. And it links to a lovely question from Kate Arden, who's the Director of Public Health in Wigan, who are, putting their money where their mouth is in terms of a bottom-up, community-driven, co-produced approach to generating health. And I think that was similar to what you're saying as well, Adam, wasn't it? Camille, any other questions which are related to that theme? I'm just scrolling through them.
There's been quite a few. So you mentioned the question from Kate Arden. There's also Joe Farrington Douglas, who's a senior policy fellow at the Lent Foundation, who's asking whether the changes that have been quick because patient and public voice has been somewhat sidelined, and a reversion to doctor knows best, and is asking whether that's the reason why COVID has exacerbated inequalities. And we've also had a similar question from Leonora Murray at the Nuffield Trust.
Okay, can I Partha, I mean, does doctor know best, would you say? I mean, have things shifted on that?
Well, partly, not really hugely. I mean, doctors don't know best. I mean, in diabetes, they certainly don't know best. We always turn around to our specialist nurse colleagues whenever we're stuck, to be perfectly honest, as everybody knows in diabetes. And that's as straightforward as that. So I think, the clinician, I mean, more than the doctor knows best, because that's the, I think there's a lot of lip service paid to actual patient care. There's a lot of tokenism, I would say. And I say that in a national role, it's quite difficult to actually find people who are genuinely interested, because I think there's not many national leaders or leaders who would put themselves out in the public domain. And I think that's a shame. People should, if you're doing that role, you should be open to taking the questions. And a lot of boards, a lot of individuals hide behind minutes or board papers, and it's easy to deflect queries, right? I have personally always taken queries from patients all across the country when they're stuck, because I have no issues with that, because it takes 2 minutes for me to sort of answer that or try and raise it. But I think the paternalistic model is still there strongly. I think the louder voice is coming through, which is good. But I think we're still a fair bit away from genuinely doing, like what Hannah suggested, co-production. And you can see that with the vaccine program, a lot of things, we're a very centralized model. We like that approach, don't we? You mentioned the white paper, it's inbuilt into us. And just to give you one example, so the whole push we have, and I find this fascinating because I did that GIRFT work where I traveled around all the hospitals around the country. So I don't know about variations of service, if I can tell you about variations of car parks around the country. But one thing I did learn is that it's this dichotomy. You talk to clinicians, right, on the ground, and there'll be one hand which says, let us get on with what we should be doing, right? And then in the other hand, you have like, why didn't you tell us what we should do? And it's a really interesting dichotomy which sort of goes throughout the NHS, which drives, and you see that on a local basis, places which really flourish have actually got what Hannah just mentioned. They've got a good co-production model. And an example of that, I'll say that actually, is one of the big challenges in diabetes care is young adults. Really tough area. Look at what Liverpool have done. Really, really good. You know, pediatricians, adult diabetologists, patient groups, really good co-production of a system, which funnily enough, has got some really good outcomes. So I think that doesn't happen enough. And one of the things I want to do is set up lots of peer support groups because, and I'll finish with this, for me, chronic disease management is based on 3 principles. Everything else is basically smoke. You give people better tools of self-management, whatever way you want to do it. You drive peer support, and we don't do enough of it in the NHS. And you give access to trained professionals when the person needs it, not like come here for an annual review. You do that, you'll have crack chronic management. And at the moment, we're just about nudging around the edges with the self-management thing. Number 2 and number 3, we're way far off from doing it. But till then, self-management or chronic disease will always struggle a little bit to get on top of things.
Okay, thanks. Adam, Hannah, do you want to come in at that point? Anything you want to add to that?
Well, I'll just come in and say that I think what Partha said there is just amazing to hear chronic health management distilled down into those 3 principles. And that principle, those last 2 principles, you said the NHS is still struggling with, of self-management and peer support. For me, in many ways, that's what community power vision of healthcare is about giving people the tools, the power, the resources to look after themselves as part of a collective, not as just as an individual. I think this is the thing that central government often gets so wrong about prevention. They think it's all down to individual responsibility. Everything we know from experience and from extensive academic research is that people, when they're part of a collective effort, are much more effective at managing their own healthcare and looking after their own health. The thing I would point out, which I think, and Partha could correct me if I'm wrong here, but what I think is at the heart of that, and is at the heart of this community-powered vision, which is becoming really influential in local government now, is you give people a sense of agency. And what the paternalistic institution does is it robs people of their agency. It turns them into passive recipients. And that in itself, alongside the social determinants of health and ill health, that for me is also a fundamental determinant of health and ill health. Do you have a sense of self-control, of agency over your life? When you look at initiatives like Healthier Fleetwood, sort of amazing community initiative to make people healthier, what people there so often say is it's given me a sense of control over my life, given me a sense of agency, whereas before I was just the victim of circumstance. So for me, that's got to be at the heart of the change that we're talking about.
I think, sorry, can I just very quickly round up that bit? Because I think one of the challenges we have when it comes to things like co-production is that people are not empowered to be able to engage with us. Frankly, if you are a mother of 4 looking after a disabled child and an elderly relative and trying to work at least 1, if not 2 jobs, as much as you might want to go and talk to your local GP or care providers about what they can do better and work in co-production, you do not have the capacity. And this is the problem. The people we most need to be hearing from in terms of how we address the inequalities that are mentioned in that question, the people we most need to be hearing from, we are disempowering by a system that just leaves them with way too much other stuff to handle. So how we solve that, I mean, I'm not an economist, whether it's a universal basic income, a minimum income floor, things like that, we need to be empowering people to give them the space and the brain space and the time to be able to engage, because otherwise it's the most disadvantaged voices that we don't hear from.
Okay, thanks, Hannah. I mean, I think all three of you are essentially saying much the same thing, which is that we need to shift to a different approach that is about co-production. It is about communities being more involved in generating health. It's about prevention. It's about tackling health inequalities. But the key question surely is that will COVID-19 make it more or less likely that we will move forward with those agendas? And what are the factors that will drive the positive answer that we want to see? Any thoughts about that?
So I'm sort of always been a very, generally speaking, quite optimistic type of guy, in the sense of, I think my only issue is, you know, in my own short career, I've seen the NHS change roles so many times. And I always say is that it doesn't matter what shape and structure you do to it, you know, all I do see is a lot of same people changing lanyards around. I think it's about the people who have got that belief, you know, and that they can make, there's a lot of leaders in the system. If you don't fundamentally, it's a bit like the whole issue that we talk around, you know, whether it's race or sexism, racism, etc. It doesn't matter how you dress it up. If you fundamentally don't believe that patients are a strong power to be on your side to actually change the healthcare system, you're not going to do it. Doesn't matter what structure you bring into the system. You can play around with it as much as you want, you know, and I think those who've been long in the tooth enough will say that the present system looks very similar to what it used to be probably 20 years ago. I don't know, you know, you just got different names as you go along. But I think what COVID-19 has done, as Hannah and Adam mentioned, it's opened up a lot of wounds in the sense that the NHS knows about, but hasn't been public enough to speak about. And I am a very big advocate of, for example, in my world, I always go around, the biggest strength that we have in the national team is trying to pick projects that has got a huge amount of backing from people with diabetes, and have that to drive a lot of change, have that to drive finances and whatever's needed. And that is something that I hope COVID will have taught people, that there are areas, and I'm hopeful that there's a lot of noise in the system at the moment about talking about tackling health inequalities. Now, I'm going to qualify that and end this with this bit to say, we've been talking about WRES and change in healthcare staff and inequalities based on race since 2015. And you could probably slide a piece of paper in between what changes that's actually done. Talking about it is not enough. And I think what we do need, if the system is serious to tackle these post-COVID, and I think the opportunity is there for people to take a fresh restart and say, okay, there are the markers to say it's actually improving. Or we may need to find some other leaders, is what I say. Your leaders should be judged on outcomes. I know it sounds harsh, not based on how nice you are and how good you look and how lovely you speak. That's my personal view.
Okay, thanks. And I think I see in the Q&A box, we've had a very helpful reminder from Jocelyn Cornwall, who knows a lot about this stuff, that we shouldn't throw the co-production baby out with the preventative bathwater, that we still need the cultural change and the co-production between patients and professionals, and prevention will not make that go away. So that's a useful point. And we had another interesting question from Nick Black, who was talking about integrated care systems. Now, I don't want us to disappear into the reeds of partnership structures, but Adam, can I take the liberty of asking you, what do you think has happened to the relationships between the NHS and local government during COVID-19? What's your take on that?
It's improved, which is a really good thing, because it wasn't that great before. But certainly the message we've been getting from councils that we've talked to extensively over the last year is they've really welcomed the much closer working with healthcare during the pandemic compared to what it existed previously. I think it was at its height at the early stages of the pandemic, when I think there was more just generally this sense of community spirit, which has obviously been lost somewhat now, but certainly it's much better than it was. And I think ICSs provide an opportunity to build on that. I'd say two things though. One is It's shifting slowly, but ICSs are still seen as a bit of a health thing, a bit of an NHS thing. It's not really yet seen as something for wider public services. That is shifting in local government, but there really does need to be an effort to be made to make it clear this isn't something that's owned by the NHS. It's something for all public services, particularly local government working with NHS in local areas. The second thing I would say is that don't pin your hopes on restructure. Everything we know about what really shifts things in the public sector is restructure can help, but in the end, it's about culture change. It's about the way people think, the way people behave within that organization and also outside the organization. So really what ICSs provide is just an opportunity, the beginnings of a chance to actually really start shifting towards this more empowered communities preventative model, but on its own, it won't be enough.
Okay, and do you think, Adam, that the impact of COVID-19 will cause ICSs to have more freedoms than they might otherwise have had within a traditionally top-down command and control NHS management style?
Well, I think if the politicians can learn anything from the last year, it's that when they tried to control everything from the centre, it was a total mess. Look at test and trace. When they eased up a bit and let local government and healthcare get on with it in local areas, it started to work. Vaccinations. So really the clear lesson is don't try and control everything from Whitehall. You mentioned the white paper. The white paper is worrying in that it seemed to suggest the solution to the NHS's problems is to give the Secretary of State more power. I don't think that's the case. Nevertheless, the white paper didn't really outline a vision, a serious vision for the future of healthcare. So I'm hoping that with pressure, with proper reflection on what's gone over the last year, we may get to a point in a few months or a year's time where actually we do genuinely have a new vision for where health and care can go in this country that is more about community, more about place and empowerment.
Okay, thanks. Hannah, did you want to comment on that? Because this was a big theme of your contribution at the beginning, wasn't it?
See, this is why I worry about video consultations. I can't work Zoom. So yes, I think, you know, as you say, this was, I'm in complete agreement with Adam on so many fronts. Test and trace was a disaster. And then once they said, you know, your local populations, you vaccinate them, lo and behold, we were able to vaccinate them and we've done incredibly well. So I think that is really important, that I always hear the words NHS restructure and white paper, and even the word Whitehall makes me really quite twitchy. And I think it fills the heart of many health professionals with fear because, frankly, I mean, I'm going to state the obvious, we're all blooming exhausted. And right now, if you throw a whole big restructure at us, no, we are not in a fit state to sit back and work with you on how to fully restructure the NHS right now. Soz, bit busy trying to catch up on 18 months worth of sleep. So I think we do need to think sensibly about how we do this and like putting timescales on it. But fundamentally, and I said my cat was going to jump in halfway through. Fundamentally, I think it does keep coming back to the fact that it has to be community led. It has to be by people who know the people they care for, and we need to think about funding. There's a really interesting question. I'm going to be really cheeky and just kind of like link into a question on the chat. Sorry, Richard, I'd like to go a bit off piece.
No,
but there's a question regarding supported self-management for people with complex conditions and comorbidities, and I think this is so important because actually what we saw prior to the pandemic, we had direct payments came out. So people with disabilities, long-term health conditions could get direct payments and manage their own care package. And that was fantastic for many disabled people because they got control, they got to say what they need, when they needed it, how it worked. And for many disabled people, that was really helpful. However, we saw the flaws in that system when the pandemic hit, because suddenly these disabled people were having to try and find PPE for their carers. They were having to manage carers that were working for lots of other disabled people and going in and out of all of their houses without PPE and the like. So I think, yes, we definitely need to be working on how we support self-management, but we also need to make sure that there is some kind of net to ensure that disabled people, as and when they need additional support, as they did at the beginning of the pandemic, actually get that in a timely manner. Because I think the worry is you kind of see this move of, it's okay, we're giving you the money, you sort out your care now. And when there's a problem, it's very difficult to get help. So we need to make sure that the systems are in place, that we're not just abandoning people to it, but it is about maintaining that communication and not just throwing money at the problem and walking away.
Yeah, sure. That's a good point, well made. Cami, I think I'm keeping up with the questions. Is there anything fundamental that I've missed so far?
No, actually, I think a lot of the questions have kind of been brought to the floor. There was one from Jeremy Taylor, who's Director for Public Voice at NIHR, who's asking about the emergence of long COVID and whether that provides an opportunity for revolution in supporting people with long-term conditions, and what would need to be done in that case.
Sure. So can I wrap that up in a bigger question as we kind of move towards the end of the session? Because the position we're in now, it seems to me, is that we have an absolutely exhausted workforce. We have the prospect of actually coexisting with COVID for quite some time. This is not just going to disappear completely. We've got a huge backlog of unmet need to be filled. Waiting lists are sort of going up by the week. And as Jeremy has pointed out, we've got long COVID. And we've got, as some other questioners have pointed out, we still have an unreformed social care system and all the problems that were revealed around the state of our care home sector. So how can we use the opportunities of COVID to kind of face up to some of those challenges? And I'm not sure any of you are going to have a clear answer to that, but I'd be very interested to hear your thoughts.
So I'll have a go first.
Yeah, great.
I think we got a fair few years of quite tough times, I think, trying to play catch up. And I wouldn't be surprised if the NHS is forced into a genuine case of prioritization. And I think a big issue in the horizon, which will be, is the whole pension issue with consultants. Because in the past, people have depended heavily on getting waiting lists down from consultants and colleagues doing lists. If it becomes so for example, if you look at the pension thing as it is, it's more profitable for me to actually stop doing the NHS England work. It's actually, that's what it is. I should stop doing NHS England work, or stop doing the GIRFT work, and actually stop doing a little bit of work at my Portsmouth hospital, and actually I'm better off. And that is a fundamental problem for a lot of people. So I think going forward, that will have a big bearing. I think prioritization will be the order of the day, and there'll be a lot of people will probably find themselves in a very disappointed position in the sense of X being prioritized above Y, and I do not envy ICSs in that position. And the worry is that lots of people who really need that intervention because of their deprivation, et cetera, will probably fall down the sort of pecking order. I do see, however, it more getting to or the things turning around, but you're looking at 2-3 years, I reckon, before we get anywhere close to getting sort of any degree of catch-up play. And the positive thing that I wanted to say is that one thing that we see, at least locally, so I'm in Hampshire, Isle of Wight, and what I do see is a huge amount of effort from and I think that's what COVID has done. It's made people genuinely think about, hang on a second, there is a big gap in the system. So the prioritization may not be a bad thing in that respect. The prioritization, so for example, in diabetes, we're talking about prioritizing people with a higher or control, which is higher, people who come from a more deprived population. Funnily enough, they do triangulate easily. So that's the sort of silver lining to that cloud, but I do not see in any way the next 1-2 years. And it's not going to be something that's solvable just by throwing more money. That's the key in this situation, is that I think there's a fundamental belief from politicians, throw more money, it's done. This one is not done. And this is a much bigger problem than money can solve. And as I suspect, as the general elections draw nearer, you'll see a lot of interesting things develop, I would say, as time goes on.
Okay, thanks, Partha. Hannah, what do you think about it?
I'm going to go a bit angry feminist politician, I'm afraid. I feel I need to kind of give people a warning of that sometimes. So if we go back to the budget, in the budget, there was no mention of women and there was no mention of social care at all. It just did not come up. And that's bonkers to me, because one of the things we've seen most clearly during this pandemic is the importance of social care. I was working in care homes during the first wave, and the things I've seen in those care homes are going to stay with me forever. And when we already knew this was a sector that was struggling, to then expect that we're going to be able to come out of a pandemic and it'll all just be fine is just frankly pretty fiscally irresponsible. We know that I'm gonna quote some stats because I blooming love a statistic. So if you put an investment into care, that will create 2.7 times more jobs, 6.3 times more jobs for women, 10% more jobs for men than an equivalent investment in construction. But we heard about things like construction, we heard about jobs in the budget, but at no point was care mentioned. COVID should be a big line in the sand where we go, right, what matters to us as a society? And what matters to us as a society should be how we care for the weakest, because I think that's what makes us human. And at the moment, we are not doing that adequately. We are not putting things in place for that. And so, yeah, I think we do have an opportunity here to change how we view health and social care, and those two are inextricably linked. We need to stop just talking about the NHS as if it's some kind of completely separate thing. It isn't. We need to combine the two together and think about how we're going to properly address this. And that is going to take investment. Yes, throwing money at things, I agree, Partha, isn't always the solution. We need wider societal change in attitudes as well. But we need to be investing in the right place. And I don't think our plans at the moment are doing that in any way, shape or form.
Okay, thanks, Hannah. Adam.
Yeah, I'm going to agree very strongly with what's been said. I mean, there is a real challenge here, and Partha has sort of hit on it, which is that politicians, when they see a crisis in the NHS, think the solution is just to throw money at it, usually billions and billions of pounds, and to say they're going to build more hospitals. You know, at some point, there's got to be a brave politician who stands up and says, we can't solve the problem of demand, which, you know, we've heard is going to get far worse as a result of COVID, just by funding acute response. There has to be a fundamental shift in the system. And every time you build a hospital, that's less money for prevention. So, you know, somebody has got to stand up. And I've also often felt, you know, there needs to in some way be almost a movement amongst patients, amongst healthcare workers, to put pressure on central government to adopt a really serious preventative agenda, to make the case for prevention. You know, why isn't there a campaign for prevention out there that's saying this is a fundamentally more humane approach to caring for people, and it's fundamental if we're going to save the underlying principles of the NHS and care in this country? So that sort of pressure needs to be exerted, or else we're not really going to take the opportunity that COVID has presented in helping us to think differently about healthcare.
Thanks, Adam. So we're rapidly coming to the end now. So I'd like to thank our three panelists for really giving us so much food for thought in a very thoughtful and distinctive way. I'd like to thank everyone who's contributed to their questions. I hope we've done them justice, and I apologise if we haven't. So thank you very much for that contribution. This session will be on the Nuffield Trust website soon. You'll be able to see it again. We've got a similar session, which should be rather good, tomorrow morning with Professor Scott Greer, looking at relationship between central and local. And a reminder again for the about the online evaluation session. But how I would like to conclude the session, and I do hope you got something from it, is to ask our three panelists to offer some concluding and very brief thoughts about what is the one key transformation or change that they would like to see endure once this crisis has passed. So I'm going to start with you, Partha, if I may.
So I think the main message I would go is that don't jump from one extreme to another. I think good healthcare is an amalgamation of digital and face-to-face and everything together. So I think that would be the main thing to take away. And I think that what we don't want to happen is, here we go, we've had a pandemic. Hey, isn't digital working great? Let's now all go digital. And as Hannah mentioned, right, forgo a lot of people. So that would be my main thing.
Fantastic. And Hannah and Adam, I'm going to ask you to be quick, because I see we've only got 3 minutes. So Hannah, would you like to go next?
I can be very quick. I would like to see a care-led recovery where that is this government's priority, because until we sort care, we will never sort health. And until we sort health, this country is going to continue to struggle economically.
Brilliant. Thank you. And Adam?
I think one of the most positive things to come out of the last year was the rise of the mutual aid movement and this massive effort in local volunteering to help and support each other. We need to find a way to keep that spirit going and support all the extra connections that have been made between the public sector and people in their community.
Adam, that's great. And to everyone taking part this afternoon, however you're grappling with these challenges, either professionally or personally, I wish you all the best with that. Thank you very much. Cheerio.